Hello. Welcome to the latest installment of the Health Storytelling Author Q&A series for 2022 and 2023. I'm Maryn McKenna. I'm a journalist and author and senior fellow in the Center for the Study of Human Health at Emory University. I'm the curator of this series, which makes me your host as we undertake our third year of author conversations. In a moment, I'll introduce you to our guest in this episode, scholar Jim Downs, and his enlightening and disturbing book, Maladies of Empire: How Colonialism, Slavery, and War Transformed Medicine, from Harvard University Press. But first, let me tell you about the rest of this year's series. At least once a month, during the academic year, we invite writers whose journalistic or academic books examine health, the science and history of health, and health's intersection with society. This series of conversations is sponsored by Emory's Center for the Study of Human Health and Emory College, and co-sponsored by the Georgia Center for the Book, an affiliate of the Library of Congress. It's live streamed on YouTube, Facebook, and Twitter, and archived on YouTube. Here are the authors appearing in this season, fall 2020. In September, I spoke to journalist Rachel Kruse for Vagina Obscura, an anatomical voyage, published by W.W. Norton. Tonight, we have Dr. Downs and Maladies of Empire, published by an imprint of Harvard University Press. And next month, on November 29th, I'll host Stephen Thrasher, whose The Viral Underclass: The Human Toll When Inequality and Disease Collide is published by an imprint of Macmillan. One final note, this is a live event. You can interact with us, and we encourage you to do that. If you want to ask a question, please comment on any of the platforms where you are watching us, and our producer, Stefan Kaplan of Spin It Social, will make sure we see what you've said. Do note that I'll turn to your questions in the second half of this 60-minute live stream, but you can put your questions in at any time and we will see them. And now let's turn to our book for today and its author. Dr. Jim Downs is at Gettysburg College, where he's the Gilder Lehrman-National Endowment for the Humanities Professor of Civil War Era Studies and History. His previous books are Sick from Freedom, African-American Sickness and Suffering During the Civil War and Reconstruction, and Stand By Me, The Forgotten History of Gay Liberation. He's been the editor of 4 anthologies and is the co-editor of both the History in the Headline series at the University of Georgia Press and Voter Suppression in U.S. Elections. He's widely published in the mainstream media, including in The Atlantic and The New Yorker. Jim Downs, thanks for joining me here.
Thanks for having me.
So, being a journalist focused on epidemiology, I am really eager, if a little trepidatious, to talk about the extraordinary and challenging ideas you surface in Maladies of Empire. But I'd love to begin the discussion by talking for a moment about you and about how you came to do this work. You dedicate the book to one of your mentors, but what struck me is that you also dedicate it to past generations of your family, and you talk about what those ancestors mean to you. You say, for my mother's maternal grandfather, who cut off her hair and sold it so her children could eat, and who passed along to me the power to persist. And for my mother's paternal grandmother, who was born with a veil over her face and healed her son's wife by chanting prayers, who passed along to me the power to see. I would love to hear you say a little more about these haunting stories and why they're meaningful to you.
Wow, so that's really going to kick it off on a different note. Okay, so I would say that as soon as I wake up in the morning, I pray in Hebrew. I pray 3 times a day. I'm a spiritual person. And so when I'm doing research, I'm thinking always about the sources that I'm reading. I'm always thinking about how to interpret the sources, but I never feel that I'm completely alone. And I feel a spiritual guidance from my ancestors, from my family, that's always with me. And a lot of times doing work in the archives can be isolating. It's not that I hear voices in my head, but I can give a quick example, which was I got to London. I was on a red eye. I got to the Wellcome Institute in central London. I went to the rare books room. I decided to go up and request the documents I wanted to see, and they wouldn't be ready for 2 or 3 hours. So it was time for me to grab a latte, a big piece of chocolate cake, and just relax. And I heard, like a voice. I just said, well, let me just look around the open stacks. And I opened up a book and I found a document that blew my mind. It was a document by the 1846 by a British doctor who went to Cape Verde and included a detailed account of enslaved and colonized people describing illness. And I was incredulous. And so when I think about finding that source, I don't think it's because of luck. I don't think it's because of I was just smart. I think that I'm guided by the ancestors. I think that when I traveled to these places and I think about all of the work that I'm doing, and I think about my great-grandmother who during the Depression couldn't feed her children and had to cut off her hair, and I'm like, I'm tired. Like, I don't feel like doing this. I don't, I'm exhausted. And I think, bitch, you didn't do anything today. Like, you haven't worked yet. And so I'm reminded of my family who had to work really hard to survive, and that no matter how hard I work as an academic, and it could be hard, it's never that hard compared to what they did. And then the power to see, we all are reading, we're all engaged in a process of interpretation, but I feel that I'm able to see things that are a result of my training, but are sometimes beyond the training. And so I feel that presence. And that's always been with me. And I put it in there to be evocative. And I put it in there because, to be quite honest with you, Maryn, when I think about this book and I think about writing this book, it was what sustained me the most. And it's with me. And I can point to all of the academic people and all of this, but it's really part of that tradition, and really part of the fact that their struggle and experience allowed me to write and to be a scholar, and I wanted to name that. So that's it. You were the first person to ask that. I thought I was going to get hit with like tons of, like, when I put it in there, and no one's really ever said anything to me about it.
So I mean, thank you for that description. And I thought I was about to hear something about that amazing cafe in the Welcome building, which is fantastic, and the cake is great.
Yeah.
But the reason that acknowledgement is so striking to me is that the project of the book is surfacing the stories of people whose identities have been forgotten or neglected, and to make the case that at the foundation of sciences that we take for granted is the suffering of obscured people. And it's really the obverse of the sort of great man, famous scientist presentation of history. And so I would really love to hear you talk a bit more about sort of how you came to that, and how you managed really, as a researcher, to recover these lost stories.
Right. So I'll just elaborate a little bit more on this one. I've always been interested in the history of medicine. I've always been interested in illness. My dealt with illness in my family, my grandparents, etc. And then my mother tells me this story that my grandmother was probably suffering from some version of postpartum, and her mother-in-law went up there and wrapped towels in her and basically chanted all of these prayers, and like that she was fine. And I thought, that story is not in the history of medicine. Now, we can talk about, there's books about folk medicine, there's book about healers. It's not completely uncommon to a certain group of people. But as a historian, I'm always interested in the people who appear on the margins, the people whose stories have not been recorded, but have definitely both contributed to medical knowledge, but have also been there in the past. And so the acknowledgement, or the dedication, was to evoke that, because it does, and you very beautifully and insightfully captured the point of the book, which is to say that, there's a question that doctors are asked all of the time. Actually, I was just in Nebraska, and this physician was teaching medical students, and he asked them, is is medicine a practice or a science? And the students all said it's a science. And to me, it's a practice. And it's a practice that results from clinical interactions with patients. And yet the stories that we've often heard are the stories of the doctors. And yet patients make visible illness. Patients tell us about sickness. I mean, so much about COVID, we can think about that. I mean, in the very early days of COVID, no one talked about the loss of your taste of smell and the loss of the smell and taste. And how did that happen? It happened because patients reported it, doctors didn't dismiss it, and then it eventually became part of the pathology. So for me, that's central to medical knowledge. And so what I was interested in as a historian of slavery was the extent to which slavery as an institution helped to contribute to ideas about science. Now, among my colleagues who study slavery, there's a huge move about how slavery helped to advance capitalism and help to build the nation. And that's resurrected old debates from Black Marxists about 50 to 75 years ago. But I was interested in thinking about how did the institution of slavery create certain types of environments that allowed for doctors to create this new branch of medical knowledge called epidemiology. And then in telling that, I didn't want to just make it as a story of, oh, wow, here are the other authors of medicine and science, but rather this is about struggle. This is about pain. This is about violence. This is about sorrow. This is about loss. And so it's about centering as much as I could from the surviving material, the stories of these people and making them the protagonist.
It's really, I mean, it's fascinating, and thank you for immediately going to the mention of slavery, because that's what we're going to talk about next. But I want to remind people who are watching us that you can put your comments in at any time. If you are watching us on Twitter, that may be a little bit more challenging. The integration is not fantastic, but on YouTube or on Facebook, if you comment in any of those, we will see them. And I'm going to take the opportunity to adjust my lighting here because it's getting a little aggressive. I think that might be a little bit better. Okay. Yeah, there. All right. Now you can see my face and not just a glow. So it's your contention, abundantly supported by the research that you've done, that the social disruptions that are described in your title, colonialism, slavery, as you just mentioned, war, allow us to perceive disease in a way that society couldn't beforehand.
Right.
They bring groups of people together in confinement or in purpose-built environments. They deprive them of agency. They subject them to scrutiny. And the recording of that scrutiny forms the foundations of medicine and epidemiology. And that is provocative and disturbing. And I would really love to hear how you came to formulate this analysis.
Okay, so the answer is the recording of that material. You very brilliantly pinpointed the point of the book, which is to say that beginning in 1750 to about 1866, you see, all of a sudden there's an uptick in the creation of medical documents that study the spread of infectious disease. Quick caveat: doctors studied infectious disease for centuries in different places in different parts of the world, from Asia, the Ottoman Empire, all over Europe. These were not the first group of doctors that ever did this. But what happens is slavery creates a massive bureaucracy. That is to say that all of these slave ships, all of the doctors on there are required to talk about the health conditions of the crew. And in so doing, they start investigating why the crew is becoming sick. They begin to study the health conditions of the enslaved Africans. They start writing about it. Those reports flow back to London. And now you have someone who's overseeing ships deployed all over the Atlantic Ocean, from Sierra Leone in West Africa to Jamaica to Cuba. And they're capturing all of this information and they're trying to digest it. At the same time, colonialism also gives way to a massive bureaucracy. So doctors are reporting on disease outbreaks in India, the west coast of Africa, again in the Caribbean. Then war happens, the Crimean War, the Civil War, again, an explosion of material. What I began to see is that the process of digesting that material, of collecting that data, and then gaining a bird's eye view ultimately allowed for the development of epidemiology. Now, you might say, well, are you sure? And here's the answer. Yes, I'm sure, because the doctors come back by 1850 and they create in London, the British doctors, the first ever epidemiological society. And these doctors that create the first epidemiological society had served all over the British Empire. And so what happens is that a doctor, say in the 15th century Venice, or sometime in the Ottoman Empire, or someplace in China, may have studied disease outbreaks, but the question of, was that doctor tapped into certain networks? And yes, there were scholarly networks and there were ways of communication, but think about how the military was able to systematize the collection of that data, process it, and then gain a bird's eye view of epidemic outbreaks throughout the Atlantic world. If we think about the outbreak of COVID, immediately when we started actually paying attention to it, the public health officials in the US could see it in Wuhan, in Iran, in Italy, in New York. That type of, we can call it surveillance, we can call it bird's eye view, we can call it mapping, that resulted from colonialism. Colonialism provided the structures for government officials to begin to map disease. And so when they start mapping it as a result of colonial endeavors or the slave trade or even war, the information funnels back to a central location. And that's what eventually led to the formation of epidemiology.
So, like anyone else who works on epidemiology, I have Jon Snow's map on my wall.
Yeah.
And you are causing me now to think about this map in a completely different way. So there is a sort of aspect of kind of, I guess, banality of evil in what you're saying, that with all these terrible projects that are confining people and depriving them of agency and devaluing them as human beings, there's a bureaucracy created to manage it. And out of that bureaucracy, which we probably would want to think of as neutral and apolitical, because it's just moving information around, is in fact something that exists to extend these profound insults to human beings.
Right. So, I mean, so the point of Snow's map, and this is the point of how there is this banality of the bureaucracy. So just a few things. One is that the map, as historians of Victorian epidemiology like Jacob Steer Williams at College of Charleston, among others, would note, actually doesn't become a key metric, a key technology until later in the 19th century, when his students, John Snow's students, actually start saying the map was central to him understanding the spread of cholera to the water pump. Prior to that, it's really unclear. But what we can see is that in the case that I gave before about Cape Verde, when a yellow fever epidemic breaks out, the doctor there, McWilliam, draws maps in order to help understand the spread of yellow fever. McWilliam is a member of the Epidemiological Society. Snow is a member of the Epidemiological Society. The point of my book is to say that Snow actually is following in the footsteps of colonial doctors who actually were studying the spread of infectious disease in other parts of the world. And then he borrows their methods in order to trace the origin of cholera to a water pump. Now, here's the thing. I'm not saying, I don't want to sort of replace Snow with just a cohort of 10 or 15 other doctors. Instead, I want to get to the point that you just mentioned. There's a kind of banality of evil there. There's an unspoken coefficient that allows for this knowledge to take place, and that is colonialism. In other words, when McWilliam develops the map, when he's actually able to extract the data, mostly from enslaved people and colonized people, washerwomen, etc., he has he's British, but Cape Verde is under Portuguese control, and he has the British Army behind him. So these people have no choice but to cooperate. So what happens is there's an extraction of knowledge from them about the incubation of yellow fever, what it looked like, how it spread. But what we end up getting if in the medical journals that he writes, in the medical notes that he writes, is a sort of reified, polished, unfettered version of how colonialism actually set the stage, how the violence of British Empire set the stage for him to extract that knowledge. And instead we get just the map. And then we could say, oh, well, Snow got the map from him. Okay, yes, but at the core of that was the violence of imperialism that allowed for the ship to appear on Cape Verde in the first place. And that can't be sort of, I guess my point is that, like, we can't disaggregate that. We can't separate that from it, even if the medical documents and the medical history is complicit in the erasure of the violence that led to the development of that knowledge.
So I'd love to hear you talk a bit more about the Cape Verde example, because what I wanted to ask you was, among all the many examples you have in the book over 150 years of ways in which people who were subjugated or organized militarily or enslaved are. I was curious. I was going to ask you which of those episodes are not your favorites, but that you find most illustrative. But I'm fascinated by the Cape Verde example in particular, because it's not that doesn't represent just the colonialists exerting scrutiny and control over the local people. They actually do a sort of citizen epidemiology on themselves and participate in the scrutiny of themselves and in gathering information about themselves. And that seemed, that really sort of rose up out of the narrative of people, in a way of people sort of taking back control of this project that was being made of their experiences.
Right. So I think that's really good. And I'm glad that you highlighted that, because here's what happens. A ship, essentially, the story in a nutshell is basically that a British ship is deployed to the west coast of Africa, to Sierra Leone, to police the west coast of Africa for any sign of the illegal slave trade. The British had abolished the slave trade, but there were still accounts of enslaved Africans being kidnapped and brought to other parts of the Caribbean. So the ship goes down there, and the British soldiers are promised a decent amount of money if they find any criminal activity. They don't. So they're frustrated, and they have to come back, and they're on their way back, and they stop at Cape Verde and they party, and they have like this really good time. And there's like 4 or 5 guys that are missing that they never show up again. We don't know what happens to them. And on the way back, the ship approaches London, and it's placed into quarantine. And this basically ignites this huge debate, because there are merchants that say, we absolutely can't quarantine this ship, because if we do, it's going to signal to all of our trading partners that we're infectious. And there are other merchants that say, if we don't quarantine this ship and they find out that we had an epidemic, no one will trust us, and thereby we absolutely must keep it, in under lockdown. So, really quick footnote: this debate about public health versus the health of the economy did not develop for the first time at COVID. This is actually traced to the 1840s. So the British government say, we're going to send this doctor down who had already done an expedition in West Africa. He's going to investigate the origin of this epidemic and to see if it's actually contagious, because at the time there was an argument that if someone had a disease, then everyone they came in contact with was contagious, and that would justify quarantine. But there were a bunch of doctors who were anti-contagion, and they said, you know what, that's actually not true. And so these quarantine rules are Byzantine and they're too harsh. And so this leads to an investigation. And so you could see the lead to epidemiology. When the doctor arrives there, as you described, these people had already performed, as you described, a kind of citizen epidemiology. They thought about the spread of it. They thought about the disease. They thought about where it was, what it looked like. And so here is a really important point. The doctor is basically crystallizing their knowledge production. He's codifying their knowledge production. It's not that they had already come up with all of the ideas. It's he's translating it and publishing it as his story. And so for me, talking about them and centering them in the narrative was absolutely key. And just one last sentence about this, because I found this case, I love this case. Other historians have since looked at it, and they don't censor the experience of the washerwomen. They tell the story purely from the vantage point of the doctor. So it's really about how you interpret the sources and who you cast as the protagonist in the narrative.
So the thing that's extraordinary to me about that story is precisely that the Cape Verde residents, get to speak for themselves. At least they are speaking to the person who's collecting the information. Okay. But there are other people who are sort of the subjects of story in your book who never get to speak for themselves. And it was chilling to me in the first chapters to hear about that infamous image of the packed hold of a slave ship. Right. That we've all seen, that has become iconic as an image of the Middle Passage, and how that actually is connected to chemistry and to ventilation and to the dawning understanding of the importance of oxygen. Would you talk for a minute about that?
Right. So the illustration is sort of iconic and used by British abolitionists to sort of to show the brutality of the Atlantic slave trade. What I discovered was, long after the transatlantic slave trade ended, long after slavery ended, by the end of the 19th century, doctors in British journals were pointing to that case in order to prove the necessity of oxygen, ventilation, and air supply. And so for me as a medical historian, I thought all of those discussions took place among the urban poor in New York City, around the tenement houses, and so forth. But actually, the case that 19th century people were using was the case of the slave trade. And now here's what's really interesting. If there's one thing the viewers need to get tonight, this is the point. Chemistry as a field develops in 1750 at the same time as the transatlantic slave trade. These are not coincidences. In 1750, scientists in Britain, in England, Germany, and France were all testing how air changes its quality by using certain devices in their laboratories. They basically figured out there is such a thing called oxygen. They always knew air was necessary for human survival since Aristotle, or even before, clearly. But the idea that air could change its quality, they started to observe that in a device in the laboratory. The slave trade actually became a laboratory that showed how air changed its quality and had a disastrous effect on enslaved Africans and led to their increased mortality during the Middle Passage. And so that the transatlantic slave trade provides evidence to a European laboratory discussion about oxygen. And so my book was trying to put those two pieces together. And so there is even the question of the construction of ventilators on ships and the ways in which Stephen Hales, long recognized as the inventor of ventilators, actually was drawing on evidence from slave ships throughout the Caribbean in order to prove how the use of ventilators on slave ships promoted the healthy circulation of air and lowered mortality rates. And you actually have in the scientific journals slave captains quoting that the death rate has decreased because the air quality has been improved. That's not something taught in the history of science. That's not something that we know when we think about where scientific ideas developed. And yet there is that deep connection between slavery and science.
So this is a perfect time to bring in one of the questions or comments from people who are watching. Let me remind everyone else, if you are watching, we want to hear your questions and comments. Put them into the comment boxes or comment on whatever platform you're watching us on. And so this person, who I happen to know is both an epidemiologist and also works in the history of medicine, points out in his epidemiology studies, his professor made an argument that the slave trade, in a twisted way, led to the first institutionalized healthcare, because there was a requirement that people needed to systematically care for the people they had enslaved in order essentially to keep their merchandise alive. Does that view make sense to you?
Yes. And I mean, I'm sort of arguing in a bigger book project that I'm working on right now that the transatlantic slave trade was the beginning of public health and that it was the first public health crisis, because there are all of the elements that we see. We see medical crisis, we see concerns about economy, we see new ways that government creates laws to respond to it. It really does encapsulate what we understand to be public health. And yet, in the United States, we've inherited a British model of telling the history of public health by focusing on unsanitary cities as the origin of public health initiatives, when in fact, really, the first public health initiatives began during slavery as a result of the conditions of enslaved Africans. So that whole structure actually gets built from that moment. And I want to just sort of say here, not to lose sight of the people, because it's enslaved Africans who are often pointing out the poor conditions, are begging for support, are asking for help, are describing their symptoms, so that their voices are not just background, but they're actually central to how these issues developed.
So another person who is watching wants to talk a little bit more about air circulation and miasma theory, and asks, what sort of fallacies existed during the time of the slave trade in regard to how diseases are spread? And to what, I'm going to twist her comment a little bit. She asks, were these fallacies motivated by prejudice or hysteria? But you talk in the book about how, particularly in U.S. systematized public health,
Right.
As it's emerging, as opposed to the British, that there's a specific sort of assignment of responsibility for their own condition to people who are enslaved or otherwise minoritized.
Right. So there's a bunch. I mean, there's definitely, I kind of reacted because I was like, oh my gosh, there's so much. So, I mean, it depends on each doctor. So I think that there's definitely arguments, and there's tons of arguments that other historians of slavery have pointed out, like Jennifer Morgan, among others, who basically have said that the people who ran these slave vessels actually understood Black people as a separate species. So there was this whole, and this actually leads to how race as an ideology develops during this moment, because as Morgan points out, they're pointing to the women, the enslaved women's bodies, and they're saying how monstrous they are and how different they are from the European standard types of female beauty and body type. And so that pointed to notions of racial difference. So that racial difference is actually informing their understanding about medicine and why they're becoming sick. There's supernatural forces. They're understanding the fact that they believe in a different God, that they don't clean themselves. There's all of these kind of stereotypes that they use to justify illness. But what I found striking was, because we know that, and other historians have documented that, was the move to investigate, that some of these doctors didn't buy that. They didn't buy they're a separate race. They didn't buy the argument that it's just a result of some supernatural force. Like Thomas Trotter in the book, they wanted to investigate. And they actually began efforts to sort of understand it, and they wrote about it. In fact, that Trotter comes up with a theory to cure scurvy by treating enslaved Africans at the bottom of the Brooks ship. I mean, this becomes a way to advance scientific knowledge. So my focus was more on how their work led to investigations that helped to provide the foundation for epidemiology as a field, even though there's many doctors and many people who also believe in arguments about racial inferiority.
So I think this is a good point in time to pop in one more question from the folks watching us, which is more about your practice, about how you came to redefine epidemiology for yourself, or to take this wider view of epidemiology and its origins. Where does that begin?
So it began really with this idea of me just trying to understand how doctors in the United States developed an efficacious protocol to prevent the further spread of a cholera pandemic in 1866. And for years, before my first book, Sick from Freedom, came out, beginning in 2011, I started collecting a ton of documents from the New York Academy of Medicine. And it was one of the only times in my research that I was collecting and collecting and collecting. And I'm like, I don't know what this is, but there's obviously something here, because there's all of these doctors talking about infectious disease. And what historians have said about infectious disease and epidemics, it didn't necessarily, their interpretations didn't explain these documents. And so I was really fortunate as an assistant professor and early associate to get grants to go to London, where SNO was, where the Epidemiological Society was. And so I was just collecting. And it was in a seminar actually with Jennifer Morgan, who I mentioned, who does work on the transatlantic slave trade, that the sort of light bulb just went off. And I started to she was talking about numeracy and demography and what that meant for the slave trade. And I started thinking, wow, this is actually about the creation of a field. And so I was really going to just keep it as slavery and colonialism. And I didn't think war, it didn't fit in terms of the rubric of subjugation. But what happens is it becomes another setting that produces more bureaucracy and produces more studies. And so in the 7th chapter of the book, I think it's the 7th chapter, it's the one on the Confederacy, I'm reading a Confederate doctor, and he's actually citing all of these British doctors. He's citing the doctors from the slave trade. He's citing the doctors from colonialism. And so then it became really clear to me that even though he was writing during the war, that colonialism and slavery produced all of these studies that doctors were drawing on to help guide them through war, which was another, as you described, like disruption and transformation with populations of people, because this is the real thing that I'm interested in, which is, again, the study of population. And the study of population is relatively new in the 17th and 18th century. I'm sure there's going to be someone who does medieval history like, well, there's a study of population. I get it, but like the formal study of population is a relatively new phenomena in the 17th, 18th century. And as the historian Ted McCormick points out, that notion of population, again, can be traced to the slave trade, to colonialism, to all of these big social upheavals that are producing groups of people that get labeled as population. And so that's how, that's the way that I started thinking about it.
So let us put a pin in that concept of population, because I'm going to come back to that in one more question. But I want to be sure to ask this before the historical context slides away from us. And that is, there are, I am sure, plenty of people among the folks watching this, because we are doing this at Emory, which has not only our Center for the Study of Human Health, but a medical school, a public health school. How should we think about doing medicine and epidemiology now? What do we owe the people who are at the center of these until now lost stories, for whom this science was literally elaborated on their bodies? How do we honor that contribution, and how do we reframe our approach to these sciences?
Yeah, so I think that part of it is just centering that story as the leading story. And part of it is that when things happen, like the public health outcome around COVID shows larger numbers of people of color suffering from COVID, or larger numbers of people of color suffering from HIV or monkeypox, it's always considered an aberration as a part, rather than as central to how public health has been done for so long. And we need to actually figure out what's happening in public health that has produced those types of outcomes, and stop treating them as sort of aberrant cases, but rather as part of a pattern. Because if we censor these kinds of stories that I mentioned in my book, then they provide a clearer context for what's happening in public health today, and to not see those cases as surprises. Like, people are like, wow, I'm surprised. You shouldn't really be surprised by that. I mean, part of it is developing a better sensitivity to how questions about labor and class actually produce, and obviously labor, class, and race produce these types of issues. And so that when we understand that, we can then better forecast why we're seeing such large disparities.
So we have mentioned a couple of times and skated on past it, the COVID pandemic. And so now let's go there. Let's return to that.
Okay.
You were finishing this book, I think, since the book was
Yeah.
actually published in 2021.
Right.
You must have been finishing it as the pandemic was beginning.
Yeah.
How did that feel? How did you associate that with the work you were doing? And did it change your view of the work
Well,
you were
yeah,
doing?
because I mean, like, I would probably have used the word epidemiology in the subtitle as opposed to medicine, but like when the title had already been decided, and epidemiology seemed too clunky, and everyone thought, people weren't going to know that, and now everyone knows at least one epidemiology, and Anthony Fauci's like a household name. Literally, before 2020 he wasn't, so people didn't know what epidemiology was. I was able to sort of explain in the chapter on Cape Verde that those women were the first contact tracers, whereas before the pandemic people wouldn't have known that. I think that one of the things is about language, and it's about how we talk about epidemics, and this also comes through in my teaching. When COVID broke out, there was this almost excitement about staying at home among a lot of people, and they were putting pictures on Instagram, turning their garages into workout centers, baking banana bread. And then we create a euphemism for brown and black people who we demanded would pick up our garbage, would stock at the shelves at our grocery stores, would deliver our food, do all of these kinds of things. And then when the number of black and brown people began, skyrocketing in COVID outbreaks, it was, well, wait, maybe there's something biological about it. And that's why I say, no, there's a labor and a class issue that's undergirding this. And if we really censor those issues, we would be able to have been a little bit more prepared to understand why COVID was breaking out in brown and black communities, and not blaming those people, because they were blaming those people and saying all of these terrible things about them. And there were times I was living in New York when the COVID broke out, and in March and April, there was no mask mandate. There was actually a debate not to use masks, that masks should be reserved for healthcare workers. And yet, I was going crazy because I hated the term essential workers. It was a euphemism that really obfuscated a class reality. And I still, to this day, I mean, it drives me insane when I hear people like, I'm isolating, I'm doing this, but you don't think, but then you expect someone to pick up your garbage. Like, I'm glad you're isolating, but what are you doing in terms of this? Like, there's this terrible class dynamic around COVID that I find really disturbing. And it even gets propagated by people like-minded people who are in public health, still not understanding, people wiping off the desk of their airplane seat, but never thinking about the sanitary workers who are picking up your garbage. Can we talk about that? Can we think about that a little bit more? Can we make their job a little bit easier? What can we do for them? And so I think that there's this, really, I think historians are going to look back on this, and people who sort of cast themselves as heroes, as like, I stayed home, I did this, without any conscious of class issues, especially how class plays out for dispossessed populations, I think is really, really problematic. And it even came through with monkeypox again for LGBT people, for men who have sex with men, and then men of color, having access to information, having access to testing, having access to vaccines. New York, I think, did a decent job in that case. I don't know about the rest of the country, but those patterns started repeating within the pandemic again.
So to respond to this notion of essential workers and how we sort of sanitized with that term what people were being required to do,
right.
I have a vivid memory of looking at the first map that was published of case rates in different zip codes in New York City,
Right.
And how the Upper West Side had a really low case rate, and aspects of Queens and the Bronx were really dark because they had a lot of cases, a really high case rate, and people asking, well, gee, I wonder what's different about those neighborhoods. Like, really? Like,
right, exactly.
It does not occur to you that the people who are in those more afflicted neighborhoods still have to go to work, have to take subways, have to take buses, are more likely to live in multifamily housing? Are we really not thinking about these social determinants of health?
Right.
It was kind of shocking to me.
That Right, exactly. The housing thing, I mean, because in Chelsea where I lived, you had public housing on one end of the street, apartments the other end. It's very mixed use. And I would always think that, I would say before the pandemic began, we were already dealing with like infrastructure problems around ventilation, around all of these other issues, 5 families sharing one elevator. So now we're talking about an airborne virus. Like, let's think about what that means in these spaces. But then also what I found really inspiring was to go back to the Cape Verde story, which is the washerwomen were the first contact tracers. There were ways that if knowledge was provided and if access was given to women in those communities, particularly, I guarantee you, those moms knew who got sick and who wasn't sick. And yet then public health sort of said, it's Dr. Birx, it's Anthony Fauci. And I'm thinking those families know what the first signs and symptoms of someone who's sick. They might not have the technology of like, is it COVID? Is it this? Because they don't have the test. But I felt like there was also a way that some of that was sort of condescending, and how the contact tracing was actually happening, because it's been happening for a very long time among all kinds of people, and it's just making people feel empowered about it. And I think that was one of the things about COVID, was just empowering people and not making it such a mysterious, epidemic that kind of made people more horrified of it.
So we keep coming back to the Cape Verde
Yeah.
example because though there are many, I think it's my favorite in the book because of the agency that those people showed on their own behalf.
Yeah.
But so to leapfrog back into the 21st century again, you also mentioned the monkeypox outbreak.
Right.
And the thing that fascinates me about the monkeypox outbreak is that here is a potentially, and at the moment in our society, actually stigmatized population, gay and bi men, who decided to take this outbreak into their own hands, to create activism around it, to do their own contact tracing, to do their own community organizing, to assail the government to get tests and vaccines out faster. And it's like a great historical echo of this 19th century effort that you describe.
That's right. And so one of the things about it is that I started writing on it and trying to report on it at the end of May, and I was in contact with the science editor of the New York Times, and at the time she didn't even know that it was a big deal. Then 2 days later, she reread the pitch and she was like, "Wow!" And they didn't go with my piece; they went with somebody else's, and he's now Times 100 People of the Year. So congratulations, Joe. I'm happy for him.
That would be Joe Osmond.
I'm happy. He got it. He got it out there, and he's been doing really, really important work. So good for him. But one of the things that happened was that if you looked at the pathology of monkeypox, a lot of public health authorities were saying things like, it's a mild disease, don't worry about it. They were describing where the symptoms were. They were avoiding saying that sex could be a way that it was being transmitted. And then right after 4th of July, I remember reading on Twitter all of these anonymous profiles that were created by men who had sex with men that described in detail the symptoms. And it was their descriptions that became sort of popularized over Twitter that really mobilized a lot of gay men and men who have sex with men to actually start taking it seriously. And then that activism pushed, the government in certain ways. However, the government really was slow and still slow around the vaccination efforts. And I think there's still lots of problems with NPX. And but really the idea that patients were the ones who were describing how the virus was presenting, where it was presenting on their bodies, what it looked like, taking pictures of it, being brave enough to describe their accounts, giving people knowledge, because really the way that it presented, it could look like genital herpes, it could look like many other different disorders. And so it was pushing for it by gay men and showing how it actually manifested on the body, that we have a clearer pathology, even though today there's still debate, and there's debate around transmission. But we have to realize that one of the big problems with it was that the government really was slow in reacting to it, and was really slow in getting vaccines out. And one of the things that happened was that just even in the kinds of vaccines, the sub-Q vaccine versus the intradermal, the fact that they had to go from splitting one vaccine that was approved by the FDA to be used as a second dose was now being cut into 5 different parts. A lot of gay men and bi men and men who have sex with men are like avoiding doing that. And Joe, among others, is like are fighting to get back to the sub-Q vaccination because it's not as painful and it's not as itchy. And so we really have to say that like gay activism was at the heart of a lot of this.
So we're almost out of time. Yeah. So what I'm hoping you'll do sort of to take us out is that we are going to tell people to buy your book. but a lot of them may not have at this point and haven't yet read it. And so this is the opportunity to say sort of like, not necessarily why people should buy it, but what about the book is important? What's the lesson or lessons, you can give us a couple if you want, that people should take away from this conversation we've been having? How do you want them to think differently about this medical history, or about the foundations of medicine and epidemiology, or about reframing their relationships to these sciences going forward?
So I would say that all of the tools, most of the tools that are guiding us through the pandemic or through monkeypox, developed as a result of slavery and colonialism. Everything from data collection to mapping to contact tracing to interviews, all of those metrics developed as a clear result of doctors being confronted with the outbreak of infectious disease across a population and having to figure out how to control it, how to prevent it, and how to understand the cause of it. And so that epidemiology as a field can't be divorced from the history of slavery. It can't be divorced from the history of colonialism and war. And it's recognizing that in the creation of this branch of medical science, there is also violence, which is to say that violence allowed for military control and occupation, subjugation, and oppression, allowed for this data extraction. It doesn't mean that we need to get rid of epidemiology. We need epidemiology, but we need to understand its origins. We need to understand how it works. It's just like when we describe, the Constitution, we the people, or that the United States is both based on freedom. The nation is based on freedom. Well, freedom can only exist if someone is unfree. So, and really pointing to the fact that the notion of freedom is tethered to the notion of slavery. And so that the founders knew that. That's why poor, dispossessed people from England and Ireland that came to the US, they were told they were free in opposition to the people who were enslaved. And that's what built the nation. Having that recognition that freedom was not just a theory that came from the Enlightenment that was practiced in the United States, but was tethered to the institution of slavery, provides us with a better understanding of who we are as a nation. Similarly, epidemiology, which is incredibly helpful and important and efficacious, is not just the brainchild of a bunch of European British scientists in the mid 18th to 19th century, but it's a science that's connected to slavery. And so much of our history is connected to slavery, and recognizing that is important. It can provide us with new insights. It could provide us with new ways of thinking, but just that understanding, I think, is really important, so that when we see disparities today, whether it's among Black people or queer people, we don't think of the disparity as accidental or surprising. We sort of understand that disparity actually led to the creation of a field. And that disparity actually led to the development of how we are basically trying to control both monkeypox and COVID.
Thank you for that. And thank you for this conversation and for this really important reminder that of the roots of the sciences that we are engaging with, and the how essential it is to recognize those origin stories and enshrine them and keep them in mind and honor the people who provided the raw material for those
Right.
stories.
Right.
So thank you for coming to talk to us about that.
Thank you so much for having me, and thank you so much for making me part of this series and for doing this series, which is really terrific.
So that's it for this edition of the Health Storytelling Author Q&A series. Please consider following Jim Downs on social media. You can see his handle there for Twitter, Jim Downs1, and buy his book, which is available at his publisher, Harvard University Press, on Amazon, of course, at IndieBound and bookshop.org, which link independent and small booksellers, and at or through, by order, your local brick and mortar bookshop. Please join us next month on November 29th, when Stephen Thrasher of Northwestern University will discuss the viral underclass, the human toll when inequality and disease collide. Until then, I'm Maryn McKenna. On behalf of the Georgia Center for the Book and the Center for the Study of Human Health at Emory University, and on behalf of Emory College, and from me, thank you for watching.